ఇంకా ఎవరు జాయిన్ అవ్వలేదు? నాకు రావట్లేదు. స్టార్ట్ అయిందా?
సార్ ఇంకా స్టార్ట్ చేయలేదు సార్.
గుడ్ మార్నింగ్. హలో,
సార్ గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్.
సార్ ఇంకా స్టార్ట్ చేయలేదు సార్.
పర్లేదు. జస్ట్ ఈరోజు నీకు మ్యాటర్ పంపిస్తాను. నాకు సాయంకాలం జస్ట్ దాని స్లైడ్స్ అంతా
అలాగే సార్.
ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ఒకటేనా? ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ అండ్ మెషిన్ లెర్నింగ్ కూడా?
మెషిన్ లెర్నింగ్ గురించి పెట్టాను సార్, అంటే మరి ఎక్కువగా కాదు సార్, బట్ లైక్ ఫ్యూ పాయింట్స్ పెట్టాను సార్, అంటే మనకి రెలివెంట్ గా.
వంశీ పాస్ అయిపోయినట్టే కదా?
అవునా సార్, అసలు మాట్లాడలేదు సార్ వంశీతో.
ఎవరితో మాట్లాడలేదు, నేను గొప్పే ఉంది
సార్. అయిపోయిందని మాత్రం తెలిసింది సార్.
లోపల ఆస్కిస్ అయిపోతే అయిపోయినట్టే.
ఎస్ సార్, ఎస్ సార్.
అనురాధ బాగా ట్రైన్ చేసింది వంశీని.
మేడం అందరికి చెప్పారు సార్, మా అందరికి.
క్లాస్ అటెండ్ అవుతుంది ట్రైనింగ్ తర్వాత చేస్తాను క్లాస్.
Good morning to all. Good morning, sir.
గుడ్ మార్నింగ్.
Sir, start చేద్దామా?
చేయండి మా.
11 ఉన్నారు.
చేస్తాను. టైం ఇంపార్టెంట్.
Okay.
మనం స్టార్ట్ చేయండి.
Good morning to all. Today, Dr. Sharda is telling about the artificial intelligence and anesthesia. Present, she is working in LBP hospital. Sharda, please start.
Yes, ma'am. Good morning, everyone. So today, sir, am I audible?
You are clearly audible.
Yes. So today I will be discussing a few things about artificial intelligence and anesthesia. So as I felt the future might be artificial intelligence, and it is quite closely related to our branch also, as we use a lot of technology while monitoring patients. So this might be useful maybe for the next 10 or 20 years. We might see a lot of change in the way we treat patients and in the way we take up cases as well. So first, technology was first made anesthesia possible, and then it made anesthesia safe, as we can see, and as it has progressed in the past many years. And then it will seek to make it increasingly scalable and efficient also in healthcare systems, pressed for resources, economic and human. So as today we'll be discussing mostly about machine learning and the use of robots in anesthesia, and implications of AI and anesthetic management, how AI can be helpful to us. And as technology always comes with some pros and cons, so ethics is most important while using this AI, and that also I'll be covering in this topic. So first of all, automation in the delivery of anesthetics. So usually, previously people used to use tools. So tools are something which humans can use by themselves to achieve some target. And machines are something in which we feed it data, and it executes the work which has been told. So when both of these are mixed together, that is what is called as automation. So what is an AI? So AI, as we all know, there is a concept of like machines which usually understand and they perform the tasks which are assigned to them in a very smart manner. So previously, there were many algorithms and there were very rules kept to use AI, and because of which there were many failures in the clinical situations. So as of now, because there is a lot of crisis for human resource in healthcare today. So that is the reason to fill these gaps, we will be needing AI, and adoption of AI will be very helpful in the near future. So what we actually mean by an AI is it is like a programming of computers, and it can actually simulate the cognitive functions of a person, of a human mind. So the most important feature of this AI is it can learn by itself. So it learns from its previous experiences, and it modifies its actions by the previous experiences. So if there is this program which can learn by its previous experiences, it is called as machine learning. So now this AI, it works like it has a cognitive computing. It understands what the task is given, and then it actually processes all the data which is already entered into its system, and then it learns from it. It actually understands what the task is given, and it learns from it. And then there are complex neuronal networks into it, which is a little difficult to understand. And then this leads to deep learning. So it processes it, it takes the feedback, and then however the user wants it to perform the next time, it does that. And then it processes the natural language, the way we talk, the way we want it to understand. It starts to learn and understand in that way. So it is a very complex way of working. There are many subsets of AI. So the first one is like machine learning, and then neural network. There's a lot of the way our brain works. It is somewhat like similar way the neural networks are there in the AI, and there is deep learning, robotics, and computer vision. So machine learning, which is a very important subset of AI. So this has already been used in various industries, especially in the aviation industry, where there is a autopilot mode. So that we are almost aware of. It is used all in automobiles also. So there are self-driving cars as well, which are still under development, but we can see them in the near future. So these are also used in quality control, in error detection, in many industries. So it usually involves a collection of data, and it analyzes the data, and it focuses on a model development. And there is a it detects a pattern, whichever is there in the data, it detects that, and then it makes the predictions, which is a very intelligent way of doing a task. So this machine learning, it can be classified into supervised, unsupervised, and reinforcement learning. So it learns in very different ways. So this supervised learning, it includes like training and testing of the data. Whichever data we give the AI, it learns and it tests whatever data is there. And in unsupervised learning, it recognizes the patterns which are there in the data. Whichever similar patterns are there, it recognizes. And in reinforcement learning, it takes a feedback from whatever task is assigned, and whatever is the output, it takes the feedback, and which is for modification of the algorithm which is present inside it. So usually the goal of these systems, which are AI based in anesthesia, it is usually we give access to the computer to whatever data, to whatever patient data is available, like the real time data, like the heart rate, the monitoring which we see, we give access to that to the computer. And we also give access to the publications, whatever publications and previous journals are there, to all those, and the previous data also. So we have something called as the electronic health record, which is quite prevalent in US and UK. So it has access to that data as well. So it integrates all these data together, and then it learns whatever has already happened. It learns from that, and then it produces some actionable information. So it gives back that information to the anesthetist as to what can be done in that situation. So basically, there are many challenges in this, because the electronic health record system, it is usually different in different parts of the world, and secondly, the cost to develop this machine learning is very, very high. So the next thing is like usually, for example, the way ML is working these days, the peri-op data, it can be used to predict the post of mortality in a few cases, and the post-induction hypotension, which we see in some cases, even this can be analyzed by the pre-operative and the previous induction data as well. So it analyzes all these things and gives valuable feedback. But sometimes what happens is, whichever it has a very complex way of processing things. So whenever sometimes it gives a recommendation to a relevant clinical scenario, but if we do not understand as to why it is giving that, because we have a logical way of learning and we are experienced in that field, so we process things in a different way. But this machine learning, it processes things based on the previous data and everything. So sometimes it gives some recommendations, which if we do not understand as to why it has given, so it can lead to incorrect predictions, and which can be very serious in our field. So it is very important for us as to understand the way AI works, the way it is learning, the way it is implementing. So today, it is mostly used in areas like risk assessment and treatment strategies. There are robots in anesthesia, which we know to some extent, and this usually it is very helpful for us because we do multitasking. We have to look into many monitors and many signs for the patient at the same time. So this can free us from some repetitive tasks like administering drugs and so things like that, and we can concentrate on the patient assessment and better outcome and decision making also. So these robots, they are mechanical systems, and they can interact with the environment and according to the directed interventions. So robots, they can support us, they can support the clinicians by doing tasks which can be done easily, like automating the task, and it can give us some recommendations based on whichever scenario is going on, and it can help us in decision making also. So there are two types of robots which have been in use in anesthesia, that is pharmacological robot and mechanical robots. So we are aware of the pharmacological robots, and these have come into existence in the recent times. So these are the target control infusion systems. So these are the first generation. They are open loop pharmacological robots. So there's something called as open loop and closed loop system. These open loop systems, what we do is we give some input and it executes a task, whichever is given to it. But it does not take a feedback from it, and it does not learn from that. Whereas closed loop systems, it gives a feedback to the machine, and then it adjusts its task accordingly, and then it does that task again. So that is the advantage of a closed loop system. For example, we know the TCIs, so they achieve a specific plasma drug levels rapidly, first delivering a bolus, and then in a steady state, it maintains that, but it does not take a feedback from it. Whereas in closed loop systems, it is a goal is set and which by the operator, and it delivers a drug, and it adjusts it to the gap between the goal and the variable, whichever variable we are setting, and it reduces the gap as small as possible. There are newer versions in this also, where they have refined the algorithms over many years. So in this, there is reinforcement learning, which we have discussed, and there is neural networking, and there's fuzzy logic to minimize the fluctuations, whichever fluctuations are there, to minimize it. They have inculcated all this into the closed loop systems. And they were initial models in which there was a single input, single output systems. Like we have seen BIS. So BIS we have used widely to monitor the patient. So BIS is like a goal. It uses BIS to again to reduce or increase a specific level of the drug. That is a single input, single output. Even the muscle relaxations, which we use a nerve stimulator guided feedback for the drug to deliver. But these are all based on a single input systems. Now we have multiple input and multiple output systems. So these multiple outputs, so what outputs do they give is they address the hypnosis, they address the analgesia, the pain management, and even muscle relaxation, everything all together at the same time simultaneously. So these are very helpful in the present scenario as compared to SISOs. So we have something called as the analgo score, which AI is using. So this is for measuring pain during general anesthesia. So for us, the way we measure pain is by the hemodynamic monitoring, by the heart rate and blood pressures and everything. So when a patient is in general anesthesia, it gets very difficult to assess pain. So to measure this, there is something called as the analgo score. And if there is any deviation from the patient's normal value, like the heart rate or the mean arterial pressures, so this analgo score comes into action. The parameters which are used are like blood pressure, stroke volume variations. So it helps to assess the pain during general anesthesia. Now, there are hybrid sedation systems which have come into existence, and this usually uses the BIS, the respiratory rate, and the oximeter combined into one thing. And then this is very helpful because manually to check all these things and to execute an action, it gets difficult for us. And the BIS guided closed loop systems, it provides a very good clinical performance compared to the manual control of the drug delivery which we do for IV anesthesia. There's something called as a MEC Sleepy, which I think we are aware of. So MEC Sleepy, this the first dual closed loop system was used by Liu et al. So what they did was they controlled the propofol and remifentanil infusions, but they used only BIS to as an input for guiding this propofol infusion. Later in 2013, they were Hemmerling and colleagues. So what they did was they developed this MEC Sleepy, and this was used for automatically a closed loop delivery of propofol and remifentanil and rocuronium also. So, but their targets which they used was BIS, analgo score, and train of 4 also for muscle relaxation. So the efficacy of this was very high compared to the previous models which were launched. And there were many scenarios in which like complex cardiac procedures and even telemedicines, this was done by a team of anesthetists who were in Montreal at that time, and they controlled the TIVA in 20 patients who were located in Pisa. So this was the way telemedicine was used. So this became quite successful in those times, and there was a closed loop control of hemodynamic parameters. This was demonstrated by NGAN. And what he did was he used a very single on and off algorithm, and this was actually used for post-spinal hypotension, which we encounter after giving spinal anesthesia, and they monitored the NIBP, and accordingly they adjusted the phenylephrine infusion. So this was the study done by NGAN-P. And there was another closed loop vasopressor controller, and this was developed by Reinhardt et al. And what they did was they maintained MAP within a very close range, that is 5 mm Hg from the baseline. In some cases, which were going on for more than 2 hours. And even this has been successful. And there was another study which was done by Jostin and colleagues. And what they did was they also used a closed loop system. They used a goal-directed fluid therapy system. So this was also a closed loop system which used a feedback also. And this was actually guided by a stroke volume and stroke volume variations. So when we combine all these things into one thing, these people, they used, these researchers, they used actually a single entity to carry out their research. So there is automated anesthesia delivery. So what we can do is when we combine all these closed loop systems like the fluid management and the hemodynamic parameters and everything, so these are called as MIMOs, like multiple input and multiple outputs. So these can be used for hypnosis, analgesia, as we already discussed. Even for fluid management also they can be used when major vascular surgeries are going on, as it gets difficult for the anesthetist to control everything at the same time. And these are the studies which people have carried out in the previous years, like the SISO systems and the MIMO systems which they use. And there's a pharmacological review for hemodynamic monitoring, hemodynamic management as well. As we discussed, these are the few studies which have been done in the previous years. So there are mechanical robots also. One of which is the Da Vinci surgical system. So this was the first robot used for intubation. but there was a problem because it had many multiple arms, and the robotic interface got a little clumsy while using it. And this was actually successful intubations were simulated in mannequins, but though its use in actual patient got a little fuzzy. So the next one, which was developed, was Kepler intubation system. And the advantage was it had a single robotic arm, and which was actually controlled by a joystick. So it has done successful intubations within 40 to 60 seconds, and this was demonstrated in 90 cases. So this was a major breakthrough for intubation from a remote area, from remote location. And for regional anesthesia also, we have a mechanical robot called the Magellan system. And this was developed, it has a block needle which is placed over a robotic arm, and it has a inbuilt software inside it for ultrasound guided nerve recognition. So this is the Kepler intubating system, which has a single arm, and it is controlled by a joystick by the anesthetist. And this is the Magellan system, which is used for ultrasound guided nerve blocks. So advantage of this Magellan system is it decreases the variability among operators, like for the time taken to correctly place the needle, which we have seen while giving blocks also. So the next advantage of this AI is in the clinical decision support system. So this CDSS, as we call it, it is a built-in algorithm which is knowledge based, and it provides cognitive aid to the anesthetist, and it helps in executing a few tasks to the anesthetist. So we have the pre-op cognitive robots and the intraoperative cognitive robots. So this pre-op robots, what it does is it detects the abnormal laboratory findings, which we tend to miss sometimes, and then it ensures the drug compliance, and then it conducts the checklist. So whatever checklist there, has it been done or not, it does that also. And intraoperative robots, what they do is identifying appropriate prophylactic antibiotics with recommendations from the latest journals and articles, and it advises us on the dosing and the schedules of these antibiotics. And there are smart alarms also. So some alarms, we have false alarms also coming up when we give anesthesia. So it helps us from not giving those false alarms. So this is the smart alarm system, and there is efficient gas delivery also. So there are multiple components in the closed loop system. There can be a software failure, there can be incorrect data entry because that is done by humans, and this can lead to a system failure, which can be very dangerous in a few cases. So the safety checks we have in this is we can override the system. Whoever is using it, they can override it, and we can do safety checks to the system whether it's working properly or not, because they are machines, they're not humans, so they tend to go wrong. And we can also make it to a fully automated mode again. So these are the very important safety considerations, because in some rare cases which might not be available in the previous data which was actually entered into the system, so in such cases it might give some error, some recommendations which might not be applicable in that rare case. So in such situations we can actually override the system, and then we can get it back to automated mode also. And it can integrate the various data also from pre-operative data to guide us for a better outcome. But this can be accepted or rejected by the anesthesiologist as in their will and from their experience. So there are some current trends in AI in anesthesia. So these are machine learning. It has been used for risk stratification. This is helpful in the intraoperative and the postoperative periods as well. So this can actually increase the patient safety, and it can decrease the morbidity and mortality as well. So it can there is a deep neuronal network. This is used for predicting the post-surgical outcomes in patients, and there there is something called as the we'll be discussing this later. There is AI and pre-anesthetic evaluation. So the pre-anesthetic evaluation, which it does is it yeah, there are scoring systems which we use to identify the risk in a patient. So, based on these scoring systems, it assesses the risk because we cannot remember all the scoring systems at once. So, there is risk stratifications, and based on the pre-operative data which is already entered, it actually gives us predictions and recommendations. So, this is taken from the EHR, the electronic health record systems, which is available. And this is useful for us to counsel the patients, to optimize the patient because before taking up for the procedure, and for even for planning the anesthetic management, what we should do to the patient in some rare cases with some rare comorbidities also. And there is this deep neuronal network which has been used for prediction of post-surgical mortality by a group of researchers called the Lee et al. So what they did is almost 60,000 patients. The data from these patients, it was taken from an EHR, the electronic health record system, and with 82 features were included in for each patient. So this algorithm, it was trained for 80% of the data, and so what it does was the ability to integrate the pre-operative, the intraoperative, and the post-operative data is very superior to the traditional way, the way we use the risk assessment modules. It is very superior to that. So for airway assessment also, this has been used in the pre-anesthetic evaluation, the pre-anesthetic period. And this can actually predict the Cormack-Lehan view, which we can see only by the direct laryngoscopy. But this analyzes by looking at the face and neck also, and which is quite accurate, which has been quite accurate based on the previous studies. And the pre-operative checklist, this which we use for the patient surgical safety, even this has been done by the AI. So AI, the way we can use it in the intraoperative care, we can what it does, it monitors the patient and the alarm systems, and for giving anesthesia, for hemodynamic monitoring, for hemodynamic management, and for clinical decision support. For all these things, it is used in the intraoperative period. So we have intraoperative cognitive robots. So what they do is they have integrated into the alarm system for assessment, for analyzing the parameters which we check every day, and it decreases the rate of false alarms which we see in day-to-day life. So whatever newer developments are there, they're usually based on the EEG monitoring, because that ultimately anesthesia is how our brain reacts and how deeply it is sedated. So the newer development, it is based on the EEG monitoring for each drug individually. So because each drug, it has a different effect on the EEG. So they are tried developing such EEG monitoring system which can be different for different drugs. And now we have the automated CLADs. Those are the closed loop anesthesia delivery systems, which we have already discussed about. They can deliver like hypnosis, analgesia, and muscle relaxation at the same time. And they have a hemodynamic feedback mechanism. So they look into all the parameters like the heart rate, the blood pressure, and everything, and they give the feedback. Accordingly, the drugs which they deliver are adjusted to the effect. And as the recent advances which we have seen is non-invasive cardiac output monitoring, the cerebral oximetry, EEG processing, and nociception assessment. All these are the basis for how the CLAD works. So intraoperatively, we have the analgesia nociception monitors, so which can monitor the pain which the patient is experiencing in GA, as I already discussed about this. So this helps in titrating, adjusting the opioid dose which we give. So the pain indices which are available, which this AI uses, is the nociception level index, the analgesia nociception index. We have the surgical plethysmographic index, the pupillometry, and the pupillary pain index. So all these are taken into consideration while delivering any drug. So this is just a diagram of how a CLAD works. So when we give a signal, the desired input which we want, there'll be a controller and there'll be a syringe in which the drug will be loaded, and then that will be delivered to the patient. So the output, the monitoring, the parameters which it takes into consideration will be recorded, and again it will be recording the EEG graphs, whichever is there. It will be giving a feedback, and according to the feedback, again the drug which is delivered and the doses which are delivered, all these will be adjusted and given in a goal directed therapy. So there have been some models which predict the intraoperative hypotension and by analyzing more than 2 million arterial waveforms. So arterial waveforms as a data were entered into the AI. So based on these, it can predict the intraoperative hypotension in patients. So this is called the super learner algorithms. So when we get to know that the patient might go into hypotension 10 to 30 minutes prior to the event, this can be a basic major breakthrough, and this can help us in buying some time to actually treat the patient and to avoid that hypotension. So these are actually based on the critical care assessment scores which are available, and the patient demographic data, the previous data which was entered into the system, the invasive monitoring data, and everything. So this ML machine learning, it has an algorithm which actually takes into account the patient demographics, and there's a predictive therapy. So what this refers to is, it is a prediction of long-term outcomes to start the preemptive therapy for effective use of the resources, and this has been very useful in decreasing the mortality rate in sepsis. So and there is also a three-dimensional ECG imaging. So what it does, this three-dimensional ECG imaging, it helps in detection of any coronary insufficiency, which which might be present in some patients. So there is manifold. This is what is called as a manifold learning. It uses ECG and ABP waveforms, the arterial waveforms, and the underlying cardiac status, whichever is there. It has a 3D image visualization, and this helps in coronary insufficiency, as I discussed. And the electronic health record systems, these are the most important, because they help in telling the anesthetist if a patient can have a reduced ejection fraction in complex surgical procedures. So there are, though it gives us all these recommendations, we again have to confirm these things based on the tests which we do, like the echo, the TEEs, and the biomarkers. But it gives us time to carry out these tests. That is what is AI useful for. And these all will ultimately reduce the peri-op mortality and morbidity. And AI has been used in the post-op period also. I guess this is okay. So AI has been useful in the post-op period also, like for opioid-induced respiratory depression, which has been noted in a few post-op cases. So this is the way we detect this is by the respiratory rate, the pulse oximeter, and the mental status of the patient. So this ML algorithm, what it does is it actually sees the irregular breathing patterns in the patient. It quantifies the breathing pattern, and it helps us in predicting the respiratory depression in the post-op period. And there has been advances in the telecommunication system as well. So there is a wireless intelligent patient controlled analgesia. This gives us a feedback pain management in surgical homes. So even from a remote location, we can actually assess the feedback from a patient pain which the patient is experiences, and accordingly we can deliver the drug. And there is this can actually be very helpful in early discharge and ambulation, because we can have a close watch on the patient via video conferences, and via effective feedback mechanisms we can help them achieve the goal quite easily even at home. And this also reduces the cost of the healthcare, and patient satisfaction will also be increased, and they'll be reacting in a very positive manner. Coming to ethics of artificial intelligence, as we have discussed everything about artificial intelligence, what we have known is it relies mostly on the previous data from the electronic health records, the patient data. So the patient privacy is put at stake when we are using all these things. It also uses the medical records also. So these are given to the researchers and the companies to develop these AIs. So here, the ethical aspects and the patient privacy comes into account, but at the cost of their safety. So there can be bias also, because there are humans who write these codes and who enter these data. So there can be flawed sampling, there can be lack of diversity from the data which is already present. So these can lead to bias in MLs, in machine learnings. So AI, it can give us recommendations by the CDSs, but it cannot replace a physician's judgment, a human mind, because a human mind can never AI can never be equal to a human mind, the way it works. So we may expect there can be sophisticated closed loop systems in anesthesia in the recent future. And for proper patient outcome, we have to work along with the AI system and our own experiences and our own skills to deliver proper anesthetic management to the patient to reduce the morbidity and mortality. So, but when we are using these AI systems, if there is any negligence, or if we are just following the recommendations given by it without a proper evidence, then the negligence, it will be have to be borne by the physician himself. So applications in anesthesia, as we have already discussed, it has a decision support system, the CDSS. It can be used in automated SS devices, like the closed loop systems, and the MedSleepy, which we have discussed. And it can also be used in virtual reality and for training programs, because in anesthesia, this is very important for simulation also, and for risk assessment, for clinical treatment strategies. For all these things, AI has been in use. Though it to conclude, though there have been a very few cases which AI has been in use till date, and the number of studies based on the use of AI in anesthesia have also been very less. And that in our daily work, using AI can be very helpful to us, and it can help us do multitasking at the same time. And the basic problem which we will be facing is, in US and UK, they have been using the electronic health record system. But in India, even now, we have been using only handwritten notes. So this will be very difficult, as the data is not appropriate, and we cannot be using the data from India to create an AI which will be helpful for us. So if there can be electronic health record system over here as well, maybe it will help us in future. And there is an article stating that robots will perform anesthesia in the near future, which is very interesting to read, and it's very nice also. It discusses the same things which we have already discussed, that anesthetist will be doing multitasking and everything, and AI will be useful. and it actually gives us an example how in future robots will be helpful to us. Like for example, the Nest will be just saying the way we ask Alexa, which is all the Echo Dot, which is almost present in all the houses. So we'll be just asking the robot as to I want the map to be in this range, the heart rate to be in this range, and the drug to be in this range and everything. So accordingly, the AI will adjust the drug dosages and the algorithms and everything, and it will be delivering the drug. And AI will be asking the anesthetist that please keep me informed about the surgical procedure which is going on, so that I can update accordingly. So this we might see after 20 or 30 years. That's it. So I have tried to create some interest in AI maybe, and let's hope for the best in the future. Thank you.
Thank you, Sharda. You covered.
Thank you,
I'm adding few points about the basic
Yes,
thing. Coming to the
Yes.
terminology, artificial intelligence is discovered in 1956, and machine learning, that is ML, that is discovered in 1959. Deep learning, that is 1965. That means a deep neural network. That's why the name given DL. Next to last, everything, artificial intelligence, machine learning, deep learning, everything added now is changed to data science. So that means DS. In past history, in 2011, Apple discovered Siri, and 14 Amazon created Alexa, and 18 Samsung created Bixby, and Google created in 2016, that is a smart speaker. Next, coming to the healthcare sector, how it is useful. Artificial intelligence means like drug development, disease diagnosis, analysis of health plans, and health monitoring, digital consultations, and surgical treatment, managing medical data, personalized treatment, and medical treatment. You already told about the manual robots and the capillary intubation system and surgical robot and RP machines. And in anesthesia point of view, in PAC, it assesses all the past medical problems and past history. And here, natural language process is very important, because we are talking English and Telugu. A patient is Oriya, Bengali, or another language, Hindi. So it automatically language change to patient. So immediately she can tell, he or she can tell the mother language. It will translate to English. So it is a help in a PAC. It
Yes,
also helpful in a physical examination, laboratory evaluation, and a mask ventilation also. In the intraoperative, to diagnose and treatment of any complication during surgical time, during anesthesia time, and can monitor the vitals and intubation placement of the ET tube, and you can remove the removal of ET tube. So these are the factors very important, and post-op also, analgesia. And in future, at present we are using tele-anesthesia, video call, webinars, conference, and OT monitoring. And now we are using OT table adjustments and AC adjustments and monitors. In future, in 2025, we can use smartphone anesthesia, tele-anesthesia, and robotic anesthesia, nanomedicine anesthesia, and genetically targeted medicine, that is genome anesthesia, and auto anesthesia working stations, and auto TIVA also.
ఇవన్నీ వచ్చి మరి మా జాబ్ సంగతి ఏంటి అంటారా?
So that is my question is, artificial intelligence is replaced the anesthesiologist or not? Now is open for discussion.
అదే అది మా జాబ్ పరిస్థితి ఏంటి అని.
It will not replace anesthesiologist, sir. At the end, we are the clinicians. We do have to make our own call in spite of all the AI.
ఏంటి శేఖర్ మళ్ళీ చెప్పు.
Cannot be a clinician at any point of time. We are, as a clinicians, need to make a call at any point of time, and we have to give the instructions to it. we have to put the data input, and we have to adjust the outcomes, and we have to clinically evaluate the patient. Even the machine is saying something wrong, something is wrong, but it might not be wrong clinically.
Shekhar, I'm really telling you, I'm not worried about you or me. I'm worried about the future generation, because nowadays,
No, sir, even the future, even in the future generation also, no machine can replace a clinician.
no, I'm not asking a machine will replace a clinician. I'm asking any machine, automation or artificial intelligence, it will reduce the number of people. Like, for example, now there are every OT require one anesthetist. Orthopedician say, I want anesthetist inside. CT surgeon say, I want anesthetist inside. So, but in America, it is actually one anesthetist is there for few theaters. I've not worked there, so maybe somebody else should speak, whoever is worked in foreign countries. Normally, one anesthetist can manage 2-3 theaters there. So like that, if artificial intelligence comes in one, like presently what we are doing, keeping a technician inside and working out whatever it is, the same way, artificial intelligence maybe work for 4 theaters, one analyst may be sufficient. So automatically the job opportunities will come down is my thinking. It's not a, it's a fear, but it may not happen also, but just thinking, it's a thought process.
That to occur, it will take a lot of time, sir, because even if artificial intelligence has into the full-blown artificial intelligence machines are there, we are using artificial intelligence, if you recognize it or not, but we are using artificial intelligence even now. We are keeping the machine, we are coming out of the OT because machine is delivering what we want. If you're using a syringe pump, we are asking the syringe pump to infuse 20 ml of NORAD per hour. The 20 ml of NORAD is going because of artificial intelligence. And even if we are keeping a 450 ml of tidal volume and a PEEP of 5 to be delivered to the patient, it is giving because of artificial intelligence. So machine can never replace a clinician unless the clinician puts in a data. Input data is to be kept by us only. So artificial intelligence is around us, is with us, and it will be with us in the future also, but it will not replace any clinician's judgment.
Sharada, you correct me because you have prepared the class. I just want to say, presently, I don't know, maybe Rani madam or seniors, anybody, or Chaitanya who is working in the ground, or any other people, Srikanth is there in different hospitals. Sir. What I'm asking is, nowadays, if you see from the beginning, from 150 years, sir, because of the automation, because of the machine advancement, the anesthesia depth and see the duration increase. So we have able to do a lot of advanced procedures, the less complications. That's where our advancement has come.
Sir, sorry to interrupt. One more thing I want to add is, this artificial intelligence will improve the patient outcomes.
That's what, because they can
using the artificial intelligence will definitely improve the patient outcomes and definitely decrease the patient morbidity and mortality.
That's what I want to actually say, that because the robotic is coming in future and laparoscopic is coming in future. So for that, more of artificial intelligence, advancement of the technology, advancement of this one, actually improve the not only the outcomes, you can take up all high risk cases and with more precision.
Yes, definitely the prognosis will be improved and outcomes will be improved.
Sir, one thing I would like to add is I will agree with Mohan sir, because in the future, AI and machines are two different things, sir. Shekhar sir said that we have been using AI, but we are not using AI, sir. We are using machines because it is an open loop system. We just input and it delivers it, but it does not take a feedback. What we use, the ventilators, the syringe systems and everything, it just delivers. So if, for example, if we are using propofol as an infusion pump, it will give the targeted amount of propofol which we are using. If the patient goes into a deeper or lighter planes or anything, it will not take a feedback from the patient based on the BIS, and it will not decrease or increase the propofol infusion. So that is what AI will do, but machines will not do that. So there is a difference between both, sir. As of now, AI in our system, as far as I know, feedback systems are not really present in our present scenarios. So in future, when these feedback systems come, the AI will be able to adjust things on its own, and it will be able to deliver the anesthesia on its own. So we might be able to manage like 5 to 6 cases at the same time, sitting in one room with our laptop in front of us and then monitoring all the cases. So what I will agree with Mohan sir, because in future there is a risk of reducing the number of anesthetists and one single anesthetist monitoring many cases at the same time, even sitting at home, maybe.
Anesthesia is a
Yeah,
very-
that might happen. That will take a long time, I think.
Yes, sir. Yes, sir. Maybe in the next 30 years or so.
30 or 40 years it will take, but it will not be there in every hospital also. Particularly in a country like us, not every hospital is run by funds or something like that, but we are people are using the private funds and everything. So it might take some time to completely evolve into AI-based anesthesia.
Yes, sir. Cost is one factor, and the basic problem is we are still using handwritten notes. We are not using an electronic health record system. So without that, there's no point in having an AI.
Sharda, you're doing electronic medical records fully?
Yes, sir. Yes, sir. In LVP, we are doing, sir. But still, there are some...
for more than last few years. I think Manjula is also in the team. She also can tell.
Yes, sir. Actually, good morning, sir. This electronic medical records is very useful, actually, mainly for the study purpose and the future studies also. But as you said that it can reduce the number of job opportunities. At the same time, I can say that there will be increase in the population, increase in the awareness of the health consciousness. More and more patients will be requiring surgeries well in advance only, and they will come for the surgeries. Even though they get more symptoms and spread of the disease, they come to the hospital for surgeries. In that, there will be more requirement of the anesthetist as well, including the artificial intelligence.
So there has been a system, a robot for sedation, that is a Sedasis, which was used in US in around, it was launched in 2008 or 2010, sir. So what happens with it was used for sedating the procedures like endoscopies and colonoscopies, sir. So gastroenterologists, they were very happy when this was introduced because they thought we'll not be needing an anesthetist in the OR and we don't have to pay them. But what happened is it was actually used just for, it was approved only for mild and moderate sedation, not for deep sedation. So what patient wants is they want deep sedation so that they should not feel anything in the procedure. What gastroenterologist wants is they do not want the patient to move in the procedure. So this could not be achieved because of Sedasis. So finally, it was withdrawn from the market in 2016, and ultimately, again, anesthetist had to carry out the task. So maybe this can happen even with AI in future also. So machines can, I don't think they'll be able to replace humans fully, but maybe to some extent they'll be helpful for us to carry out the task.
The same thing I was about to explain. That thing is, when you see a patient, you assess him clinically, you assess him seeing his build, you can assess everything by seeing a patient as a human being. Whether the AI can do that by seeing a human being without seeing a clinical record is highly doubtful, and it cannot give the same amount of drug or the same amount of sedation for every individual. It cannot calculate like that as of now, because it needs a human touch to understand the patient and to give the amount of drug that the patient needs for a adequate sedation or analgesia.
Hello.
Yes, madam.
Hi, good morning. Yeah, I was going to say the same thing. First of all, you need intelligence to use or create artificial intelligence. So, yeah, you have to be that smart to utilize it properly and to put all the information in the machines. And still, you don't know. Individual people's patients' PKPD is different. Individuals' response is different. To use that machine, you may need a lot of monitoring. Yeah, as she said, nerve stimulator, maybe sedation, like a BIS, and so many things it may require to assess the level of consciousness or level of sedation for the patient. So all that you need to provide, and you have to monitor all these monitors and AA. And even then, like each patient's response is different. I used TCI and TCI for a like a alcoholic patient, as per like height and weight, everything concentration it gives in how much per ml concentration it should maintain, it gives on the machine. And we thought like we'll put more than that because this patient is alcoholic. So we set higher than the actual recommended it. But still, the minute orthopedic surgeon started doing the procedure, the patient suddenly sat up. So they were suddenly shocked, and we had to give big bolus and again make him lie down. And even with double concentration also, we couldn't maintain. And we had to give relaxant proper GA. We had to convert. Couldn't manage with target controlled TIVA. So this is what happens. Individual variation is lot. And if something happens to the patient, nobody can sue on AI. They will sue the concerned anesthetist only. They'll sue the concerned anesthetist, not the AI. What can they do? So eventually it will be the responsibility of anesthetist, whoever is monitoring, whoever is using that. So we have to be even more careful when we use all those gadgets. I mean, I'm not saying it shouldn't be used, but it can't replace us. That's what I mean to say. You have to supervise on top of it, and you have to monitor patient, those gadgets and everything also we have to monitor. Then only it works. And if any consequences, we have to take machines or so no mind. So they blame only anesthetist. Thank you.
Any artificial intelligence needs electricity. If electricity is not there sometimes, and I mean power cut, that time it works or not, we don't know. So we have to go for vigilant only.
Yeah, like in our country, lot of power cuts. So need to check the battery backups and everything for them, how long they work. Yeah, true. Thank you, Sharda. Thank you, Anuradha.
Thank you, ma'am.
Thank you, ma'am.
Any questions from audience? Sir, close chesena.
Thank you, Anuradha.
Okay, thank you so much. Thank you, Sharda, for enlightening the good topic.
Thank you.
Thank you, ma'am. Thank you, sir.
Very nice. Anuradha.
Thank you to all.